morning, everyone. Bonjour. Say good morning to them. Thank you very much. A quick picture of the place I now work in, which is slightly different from Our Lady's Hospice to a 3,000-bed hospital. But I was asked to speak about developments internationally in palliative care. And I'm going to probably draw on my work in the EAPC quite a bit in this one. Sorry, wrong way. There we go. So I'm going to try and cover a couple of things. There's a bit of an echo. Is that me? Is that all right? Yeah. One is around. Is that better? Is that better? I actually don't really use a microphone anyway. I'll stay back from the microphone as best I can. One of the areas is around new policy directions. A bit of an echo. And some of the new policy directions that have actually happened in the last year, which I think are important for palliative care. That better? Yeah, that's better. Okay. I'm going to talk a little bit about what might be considered a new palliative care. Perhaps not a new palliative care, but particularly looking at the concept of where community sits, because one of the big changes we're seeing, certainly in Europe, is around the place of community as a driver for palliative care. One of the big areas that has become very popular at the moment across, certainly in Australia and certainly in Europe, is around the care of marginalised and disadvantaged populations, which I know was mentioned earlier by Biwi. So I'm going to talk a little bit about that. And then just a note about clinical practice. Is there anything new out there? And there's one or two things that's happened which I think could be quite interesting going forward. So let me look at the new policy directions and old challenges. One of the main things that you may be aware is that the Council of Europe have brought out a new policy document, a new plan on palliative care. So this was originally done in 2013. And 2 years ago, the Council approached me and said, we'd like the EAPC to help us to refine and redevelop that palliative care in light of some of the changes that we can see happening. So I need to explain how the Council of Europe works. So the Council of Europe base half their time in Brussels and half their time in Strasbourg. And they have a system of what they call rapporteur. And the gentleman that some of you may recognize is the gentleman who was the rapporteur for our Council of Europe report on palliative care, and he is from Ireland, and his name is Ronan Mullen. And the way that the rapporteur works is they have to be chosen from a country that is considered neutral, and they have to be considered somebody who is not considered partisan. Now, some of you may have a particular view about Mr. Mullen, because Mr. Mullen would be quite a strong character here in Ireland about certain issues, as you know. But in fact, in relation to the report, I would have met him a number of times, and the Council of Europe did a number of site visits around Europe to look at examples of good practice and where palliative care practice needed to perhaps improve. They focused a lot of their work around Spain, and the reason for that is that Spain has very diverse examples of palliative care. In the Catalan region, this is one of the challenges, because at the time of this was at the time when there were difficulties between Catalonia and Spain. But Catalonia has very, very good examples of palliative care led by people like Javier Gomez Batiste. But if you go to other parts of Spain, particularly Extremadura, which is down in the south, they have very little palliative care. So they were able to compare and contrast examples. They also visited Romania, they visited Tajikistan, and they visited Germany, because these are all, the reason they went to Germany is because Germany has a very federal system, and many European countries utilize a federal system in terms of how their healthcare is managed. So what did the report say? Well, if you read the 2013 report, it was really reiterating much of that, but there were some new things that came out which I think are relatively important. And for the first time, the Council of Europe recognized that palliative care has significant economic repercussions. And basically, unless there is money that follows the patient or follows a system, then you cannot provide good palliative care. Because in many countries, palliative care is still provided from a charitable context. And that is not sustainable. Many countries, although it may have some place within their healthcare system, it isn't always the main driver of the service. And so one of the things they were saying is that finance ministers, so a lot of the work of the council, when I went to present to the Council of Europe, I was presenting to the ministers of state, and particularly the finance ministers, around why palliative care was important. And I was presenting, I had a colleague from Finland present, and a very interesting man who is from France, and he is an advocate of respite care. And this is very interesting because the Council of Europe are very concerned that palliative care has in some way lost the concept of respite care. And so they wanted to keep saying, well, how do you deal with respite care? Where is respite care today in the delivery of palliative care? And the French example, this particular organization provides respite care for whole families. So it takes the patient and the family to a place of respite where there's carers for the patient and the family are cared for as well in like a hotel type situation. So that respite care was very important. One of the other things they said, which is very good, because internationally we hear a lot about palliative care and where palliative care is good and bad. But in Europe, we have wide variety of access and big problems in terms of access to palliative care. And the Council of Europe acknowledge that there are many people in Europe who simply cannot access palliative care. And in some cases, that's due to things like rural isolation, because we have people who live in very isolated villages, many miles from access to GPs, many miles from access to decent healthcare services. They also raised the issue about the cost of hospital admissions, and they did a cost-based analysis, which you can read in the report, which actually questions why are patients with palliative care needs brought in through emergency departments when they should find a different way of being able to do that. And then the other one, as I say, is around respite care and the role of informal caregivers. I suppose if I look at it, what they're saying is, they've said this in the 2013 report, but it's really about the integration into the health system, that the idea that charitable-based systems of care are sufficient to provide good palliative care no longer exists, and we need to remove that. They call for the removal of obstacles that restrict access to pain-relieving medication. That's a general call around what they call access to the essential medications of palliative care, which is a global call, but the Council of Europe recognise that. But they're also, one of the things they learned from going round is the wide diversity of training and access opportunities for training for people who wish to work in palliative care. And the argument between specialist and generalist, but largely speaking, many countries simply do not give options for people to do palliative care training. And that what they're arguing is that has to be part, and some of that comes up later in my talk, is around how we engage with universities and third level establishments to ensure that palliative care is part of their curricula. So that's one thing. That's the Council of Europe. They've been doing good work. This report will probably, what will happen now is that this report will now be presented at the next, it was published earlier this year. It will now be presented at the next state ministers meeting, which will be in Brussels in May. And then it will become extant. And that means then the ministers will then go back to their own countries and say, you need to do this. Council of Europe has said so. The second issue I want to raise is this one. There has been a call for a new definition of palliative care. Are we all aware of that? Everyone knew about this? And this is important. I think it's important because I think this is going to be a very significant challenge for those of us involved in palliative care over the next, certainly the next year to 18 months. So I just need to give you a little bit of background to this. Currently, internationally, there are 3 organizations involved in the global development of palliative care. One is the IAIHPC, the International Association of Hospice and Palliative Care. The second is the WHPCA, the World Hospice and Palliative Care Association, or sometimes called the Alliance, which makes me think of Star Wars. And the third is the EAPC, European Association. IAIHPC hold what's referred to as official relations with the World Health Organization. So to hold official relations with the World Health Organization means that the World Health Organization gives you a mandate to represent their views. And what we are aware of is that, well, there's 2 sides of the story. One side of the story is that the World Health Organization concerned that the current definition of palliative care was still too specialised and still didn't give enough understanding of the breadth of where palliative care could go and the challenge of providing global palliative care, wanted to revise the definition and gave the mandate to the International Association of Hospice and Palliative Care to do that. Conversely, the argument was that actually the AIIHPC went to WHO because they are predominantly an advocacy organisation, and said, we feel that we need to change this definition. So you can choose which side of that argument you wish. But what they did was they developed an international expert panel. I was part of the panel from my role in EAPC, with the idea to review and revise the current definition. So what happened was the 40 experts around the world were sent the definition, and you were asked to review the definition, and did you agree, did you want to change, and was there something that was agreed or not agreed? And eventually we had to come to a point of consensus. Now the reality is we didn't. It was not a Delphi process. I want to be very clear about that. I have seen it said as that, but it was certainly an expert opinion review, I would agree. And it was sent for wider consultation. And as you can see, a large number of representatives of organisations have agreed, as well as individuals. But there are also organisations that have said we cannot agree with this, and I will show you what the new proposed definition is. EAPC is one of those organisations. Asia Pacific has said no, and WHPCA has said no at the moment. The South Americans have agreed to it, and of course the USA, because the AIIHPC is a USA-led organisation. So what is the definition different? This is maybe a little bit small. But I think the bit that's important is that we're all very well used to the language of life-limiting illness. The new definition, as you see, talks about holistic care for all ages with serious health-related suffering due to severe illness, and especially at end of life. And that line has caused the greatest controversy. People are very uncomfortable with this because there's almost, I've heard people say, for anyone who has a severe related illness should have palliative care. Anybody who has, a serious health-related suffering should have palliative care. So if you're somebody who has a mental health problem, you should be able to access palliative care. And then there are other people that saying how do I do that in practice? How do I clinically enact this in the scheme of my role as a nurse or as a doctor? I can't do that. And that has been part of the debate that's gone on in terms of whether this is agreed or not agreed. Obviously, I agree it should be evidence-based. There's a stronger emphasis here, much more as we heard today from our previous speakers, around the primacy of the patient to be able to make decisions, so according to patients' needs and wishes and preferences, which has a significant shift in the way in which some countries might see palliative care practiced or developed. But I think also within this, it makes a particular reference to basic palliative care training. So education is mentioned for the first time. It isn't in the previous definition at all, actually. And also says that there is a place for specialist palliative care, but it's much more around the generalist approach to palliative care, with the context that fits wider with the global situation of need. Now, one of the issues that's come up is that in order to prepare this definition, they've had to prepare a glossary. And there would be an argument that if you have to have a glossary of terms to explain what you're doing, it's not a definition at all. And that's been another point of argument. But this is just, you can get this, you can download this from the, I have to say this definition, of course, is from the AIIHPCA. It's from their dictionary of terms, which is prepared by Professor Wenck from Argentina. So they explain here what suffering means and what serious illness means. So associated with any illness or injury of any kind. Severe illness, any acute or chronic illness and or condition that causes significant impairment. The challenge is that there are strong parts of this that I think most people can agree with, but will we ever get a consensus on this? And part of the challenge at the moment with this definition is that to accept this definition would require a change to the WHA resolution 6914, which all of you know ultimately or intimately, which was the one that was actually said that all states need to incorporate palliative care as part of their healthcare strategy. The WHO have now said that to accept this new definition would require a revision of that, and they're not sure that they can do that. And so This is and it has become a political issue, but it's a very strong debate. And in fact, as you know, the APC has a meeting in Berlin, and we're having a roundtable discussion to try to understand how we bring those perspectives together. But one of the things that's become very clear by this, and certainly the Council of Europe report, is that palliative care is now a very strong political issue, and political messages matter in how you actually engage with the decision makers in your various countries. And so they're arguing in this new definition, this is the second section of the definition, things like, do insurance plans integrate palliative care appropriately? They make a particular reference, much to the annoyance, I have to say, of the International Children's Palliative Care Network. They make a comment here about pediatric formulations, which, because there was nothing in it about children, the children's have a separate definition. But they wanted to include it because I understand the need to try to bring all parties together. But I was speaking to the lady who's in charge of that, and Julia was saying it doesn't work for us particularly well. They do mention vulnerability, which is, as I say, a big issue I'll come on to in a moment. And it does mention this issue of engaging with universities and academia. So it makes a strong case that education is important. And so, whether or not you agree with the definition, you may have views, you may have comments, but it is an issue that we're going to have to debate. Whether WHO will accept it is a different story, but the WHO have their large meeting later this year, and I'm absolutely sure that this will be on the agenda. So you need to watch the horizon and see, because you could find yourself working from a new definition within the next 2 to 3 years. We don't know. I mentioned about palliative care in terms of community foundations, and why is that there? Well, I mentioned the WHA resolution, and that's very much making this point that palliative care is a public health issue, strengthening of palliative care as a component of comprehensive care throughout the life course. The booklet here, which is written by Xavier Gomez and Stephen Connor, there's a second iteration of that now, and in fact what they're doing is they are developing a whole toolkit of resources for trainers internationally to be able to utilize this book to embed the public health message, or embed palliative care within a public health message. And that work should be complete probably by the summer of this year. But one of the things it's basically said very clearly is that we need to look at how communities are involved in the care of our patients. And I'm going to give you one example of that, and the program is called Todos Contigo. So Todos Contigo, if you speak Spanish, means we together or all together. And this program originally started in Spain, but it's actually now based in Colombia. It's actually working out of Colombia, and it's gone all the way through South America, and is now coming back into Europe. And the New Health Foundation, this is an example of where organizations are taking up that public health message, maybe more than some of our institutions are doing so. And they're going out into communities and they're saying, how can I support you to develop palliative care in your community for your citizens, for the people that you care for? How can I get the people in this region to provide the care? Many of you may be familiar with some of the earlier iterations, the Kerala project, the Compassionate Cities project. It's all tied into this context. So one of the things that they've done is they have this Todos Contigo, they have a set of palliative care programs, and what they do is they go into areas, usually areas of quite high deprivation, and in Colombia, some challenging areas too, and they help them to develop structures so that they can develop palliative care networks, they can develop clinical practice, and they provide these PALEX guidelines, which are basically, it's a little bit like a quality assurance process, to make sure that across Colombia, for example, if you have one in Medellin, which is one of the main cities, or you have one in a rural part, that there is some quality assurance between what palliative care means here and what palliative care means even though it may be delivered differently. How they do that is that they've developed an observatory, which you can actually download, and they do a lot of best practice identification. So they identify good examples here that they can then translate, which is a little bit like you were saying, this is a good example here, can we translate that over here? They do a lot of real case analysis. One of the things they use are things like Zoom, where they have maybe a little bit like the ECHO project here, where they have all the nursing homes online and you can bring people together to talk about real case situations and give people real-time solutions to manage complex care. But they also then have publications and professional discussions, so they have groups of professionals coming together to see how they can improve that. And within that, they always like, particularly I think in South America, they like declarations. So they have the Declaration of Medellin from 2017, which is basically saying that, in fact, which I think is interesting, and it is a message that you are hearing globally, that death should be socially assumed. Death is a social process, not a clinical one, which is an interesting thing, I think, for clinicians. But we have a responsibility to care for people in our society. Compassion is the basis of our existence as human beings. Now, bearing in mind, this is in Colombia, which has many political challenges, and it's in Venezuela at the moment, which is people challenges. And we have people have the right to die and to be cared for by people who are kind, humane, and respectful. They're not strange things to ask for, but the best care at the end of life is the responsibility of each and every one of us as citizens. So there's an issue of individual responsibility which is seen as critical here in terms of development. This is one example of a number of projects that are happening. There's one currently in South Africa that's happening in Soweto, in the townships in Soweto, which is using this model. So there are many good examples of community engagement, grassroots community growth. And many of the people who are involved with this they're not clinicians, they're community workers, they're community activists. So we need to think, how different will that be for us who may work in a different way in Europe? I mentioned to you earlier that, I'm just conscious of my time, I'm moving on, focus on care for marginalized and disadvantaged populations. This seems to have become a very, very large call across many European countries. And I'm just going to talk you through some of that now. There's some interesting derivatives on that. A lot of this, of course, comes from the context of vulnerability. Now, in the English language, we don't like the word vulnerable because it implies something. It implies, I consider you to be vulnerable. So we tend not to use that, and we tend to use marginalized or disadvantaged to describe the situation. But actually, in many of the Latin languages, they tend to use vulnerability as their key word. But I use this example. This is an example from Canada, who are leading a lot of this work, which says that it's fine to have multiple descriptions because it will vary by country and politics. And I'll give you a very quick example. In Switzerland, we do not have a problem with homelessness. Homelessness is not considered a problem. If you mention homelessness, people look at you and say, what are you talking about? We do have a problem, however, with addiction to medication and drug addiction, and many of those people are homeless. But it's not recorded as homelessness. It's recorded as their problem with drugs. So that's one of the challenges when you look at what vulnerability means. Different countries will record it in different ways. This is just, I think what I like about this particularly is it talks about the obstacles that people face when they encounter social, economic, or political or environmental resources. So again, it's this idea that what people suffer is generally a challenge in terms of their expectation in society. I think the challenge for us in palliative care is to what extent does that then divide our society? Are palliative care guilty in some way of consciously or unconsciously dividing people? The idea of cancer versus non-cancer. The reality, however, is all men are created equal. It doesn't make any difference, because if you are rich, but you're socially, we know that these things make a difference in terms of your expectations and your likelihood of a good death or a bad death. And there's an example I will give you. So a man born in the USA will usually live about 40 years longer than a man from Zambia. But a homeless man in the USA will usually live to the age of 40. So there are we know that the social context makes a big difference to how people live and die. I just want to very quickly flick through this because I think this is interesting. There's a university in Canada, Queen's University, that develops this thing which is called the Multiculturalism Policy Index. And I just want to point us out, we're here. So basically what this is how well do countries have policies which support multiculturalism and issues of challenge and vulnerability? So this axis is the percentage of people from different countries and cultures that are living within a particular state. And this is how well they score on policy. So 8 is very good and 1 is not so good at all. So here we are, Ireland. We don't have a huge number of people. Look at Australia, very good over here. Generally, they do quite well on policy. We're not so good over here at all. This is done every 10 years. If you look at 1990, Ireland's still over here. We haven't done very well. And if you look at 2000, yeah, we're still over there. The population is rising, but our policies are still not good. And the reality of all of this is that at one level, we talk about providing integrated care, but we still have huge swathes of our populations that are excluded, either because of culture or because of language or because of misunderstanding. And actually, I think Ireland may, when they do it again, I didn't have the 2010 with me, I'm sorry, but they'll do it in 2020. I think we'll see a difference in Ireland because there has been a shift in terms of how that works. So I just want to make the point that, you know, caring for people who are marginalized and disenfranchised is really around poverty. And that's one of the key issues across many countries now, is where does poverty, not just financial poverty, but poverty of spirit, when people cannot find a way through. And what is our responsibility in palliative care? Because we like to be immune to that, but we live with our challenge of chronic niceness. Read Peter Speck's work about how nice we are and our nice patients and our nice hospices, and we like a nice death. And that's not the reality for many people globally. 2 quick examples. One of the big projects that you're seeing across many countries in Europe, including Switzerland, is around prisoners. The lady I'm showing you here is Mary Turner. She does a lot of work. A very good example is in Switzerland, I don't know the Irish one or the Swiss one very well, 82 out of every 100,000 people of the population end up in prison. In the United Kingdom, it's 187 per 100,000. Across Europe, what we know is it's mainly men. And if you look at many of the European prisons, they are mainly migrants from Eastern Europe, people who are themselves disadvantaged. Challenges that Mary talks about, which I agree, is death with dignity in prison really possible? And some of that depends on how you see prison. Do you see it as a place of rehabilitation, or do you see it as a place of punishment? Compassionate release is a huge challenge. There's a big study going on in Switzerland at the moment, and actually in French-speaking Switzerland and in France, looking at this issue of compassionate release. What does it actually mean, and how do you manage it from a bureaucratic perspective? Because actually in the care of prisoners, bureaucracy is often the challenge to the provision of good care. The other area is migrant and refugee populations. And the country that's doing a huge amount of work in this is Germany. Professor Friedemann Nauch in Göttingen is doing a significant work in this area, because they had many of those migrant refugees who came to Germany. They would meet them off the trains. Many of these patients had significant health problems, chronic health problems, and end-of-life conditions. The greatest problem is around language and culture. I work in a country now where we have 3 languages and 3 cultures. We have to find a way to accommodate each other. We go to meetings, you can speak in German, I can speak in French, she can speak in Italian, and we have the right to speak our own language. Try managing that in a case conference. The reality is that often the patients who come exhibit displacement and social isolation. And for them, the question is, how do we understand what the meaning of life and death means from people who have come from such tragic circumstance, or have come not just as economic migrants? And one of the things I'm seeing is that the Europeans don't like the term economic migrant, because it implies I'm just moving because I want more money. And often their migrancy is not related to that, because they still bring all the challenges and problems. So I think, just to say, we need to improve some of that work. There's really good work happening. Australia has started a new program now around this area of migrants and how they manage it, because they have had really bad publicity about how they manage some of their migrant populations. But we need to consider around, particularly the point at the end, which is about the integrated care programs, which place the value of the service user in the decision making. And it goes back to much of what was said earlier this morning. I'm coming to the end. Some new ideas for clinical practice, just some points to make. Well, the main thing many of you may be aware of is that there has been a large funding stream in Europe, Horizon 2020. Some of those have particularly started to look at some of I suppose, clinical engagement aspects. I'm just mentioning 2 here. One is DIADIC, which is a new program which will look at, it's an international randomized controlled trial, looking at how we support advanced cancer patients and their caregivers in terms of care at home. So it's a comparison between a web-based intervention and a nurse-led face-to-face intervention. The MyPal project is looking at adults and children with cancer, interestingly still cancer, and particularly around advanced patient-reported outcome systems. So what's interesting, if you look at how these have done, they do look at the clinical, but they're looking at the clinical in the context of that wider picture. And the Horizon 2020 program made that very clear. They wanted to see how does it fit within the system. And the third one then is the issue around palliative sedation and proportionality. So there's a big study going on. I think that's actually the largest study. I think it's about 14 countries that's involved in that study, which is looking at how do we manage the proportionality of palliative sedation, and what does it mean? Because in different languages and different cultures, it means very, very different things. The other one I'll just note is this particular study. So many of you will know David Currow. And David has been leading a lot of work around the evidence base for the use of low-dose extended-release morphine for the symptomatic relief of chronic breathlessness. Now, the reason I'm mentioning this is it's been approved now by the ATGA, which is the Australian Therapeutic Goods Agency. They haven't decided which particular drug they're going to use, but it's the first time there's been a registration to say that this works. And they've done lots of, you can read the papers and the studies. It's now being considered by both the FDA and the European Medicines Agency. So it may be a game changer in terms of how we manage this particular problem. The patient cohort they were tending to work with are people with heart failure, and heart failure, more not the cancer patient, but more the chronic patient with heart failure or COPD. But he said, I was speaking to David about it just to make sure I knew what I was talking about, and he said the big thing you will see is that future clinical trials will change in relation to this. So I think in the next 2 years, maybe the FDA and the European Medicines Association will follow suit to the Australians. He thinks they generally will. In fact, he's actually speaking with the European Medicines Association, this agency, this week. So there are some good things happening in terms of shift and change. We need to be open to that as we go forward. So just to conclude, the one final point I want to make is that end of life, it's an important notice. There is a big debate at the moment globally. Have we lost something around our discussion on end of life? In our move towards integrated palliative care and early intervention of palliative care, all of which is very good, have we lost something around the care of people at end of life? And people are saying we need to think again, because actually when patients and families often need us most is at this point. We can intervene earlier, but we come into our own here. But are we at risk of losing it? And I think it's a very important question to consider. So what I would say in conclusion is that there are many directions. Many countries are being involved globally. There are huge developments. But I think one of the key messages that we can no longer account for good palliative care unless we consider the socio-political dimension, because palliative care is becoming a political, I don't want to say football, but it's certainly becoming a political issue. And the main condition for clinical decision making, it would seem, in base on vulnerable populations and all those challenges, is respect. And what do we mean by respect? And how do we make sure that we uphold principles of respect, which can be for us both challenging and supportive? And so I think looking forward, we have lots of new horizons to explore, but we will have complex decisions to make. Do we agree with the new definition of palliative care? How do we care better for our vulnerable or marginalized and disadvantaged populations? How do we make sure that what we're doing meets that spectrum of care from early intervention to end of life? Thank you very much indeed.